Hello, and thank you for joining us today for this conversation on the occasion of World Cancer Day. We have with us Dr. Hari Menon, who is a medical oncologist with 20 plus years of experience. Currently, he's working as a director and senior consultant of Haemato Oncology at Cytecare Cancer Hospitals in Bangalore. He has worked with one of the most premier institutes in cancer treatment, education, and research in India, that is the Tata Memorial Hospital, for a large chunk of his career. And today he's with us to answer some of the most commonly asked questions and to share his insights on cancer and the treatment, the cure, as well as the preventive measures. Thank you, Doctor, for joining us today, Dr. Hari Menon.
So when we talk about what is cancer, cancer is a we can call it a disease of the human body, which is related to every cell that is there in the body. We know that there are the whole human body is constituted by cells. Cells constitute tissues. Tissues constitute organs, and organs constitute a system, and a system and multiple systems constitute the human body. So it happens at the cellular level. So the cells are constantly dividing, and these are very tightly regulated processes in the human body, well controlled, and never goes out of hand. We like to call it as a very closely orchestrated process in the human body. And sometimes these divisions can go rogue because of certain abnormalities, like mutations that are acquired due to environmental stimulus, or because of any sort of genetic predisposition. Though we must say that genetic predisposition is a small aspect of cancer pathogenesis, as we call it. But when we talk about acquisition of cancer, it is basically the cells become rogue and they start proliferating or dividing uncontrollably without being checked by the various checkpoints that are existing in the body, which also includes the immune system. And so when this happens, they tend to outgrow many of the normal cells and start exerting their, start bulldozing their way. I'm sorry, I think I have.
Yes, your video has.
Yeah, okay. Yeah, so it starts bulldozing its way of the normal cells, and sometimes these cells tends to start leaving their site of occurrence and move to other parts, which we call a spread of the cancer. And primarily, it interferes with the normal functioning of at the cellular level, at the tissue level, and at the system level, because of which the human body tends to break apart and actually eventually culminates in a mortality. So it's basically uncontrolled proliferation of cells which happens, and that is what is cancer. And it can develop in anybody. We generally consider it as a disease of the aging population. We see more cancers as the patient grows older. As is true today in any part of the world, we see increasing amount of cancers because the life expectancy has improved considerably in various parts. We see more cancers. Earlier in India, much of the cause of death used to be because of infection and cardiovascular risk, and now you see that cancer is only second to cardiovascular diseases causing mortality in human beings. So now, so can we? So when we say that, what is cancer? It can happen to anybody. And even as I talk to you, there are cancer cells that are being formed in my body and getting eradicated also by the body because there is an active immune system that is prevailing. And this is something that happens everywhere in all human beings, all organisms for that matter. For example, if you talk about the sharks, which has got the most robust immune system, it is said that you hardly find cancers in sharks. Yeah, so it's the same thing that happens in human beings. When you have an active immune system, it tends to take care of the development of cancer, and it is nipped in the bud as soon as they develop. And whether your second question as to whether cancer is curable, it is just like any other disease that the human body develops during their course of their lifetime, and it needs to be dealt with accordingly. And I always like to resort to the quote saying that the rule of 1/3, as I call it, 1/3 of the cancers are well treated and cured completely. There are about 1/3 of cancers which are well controlled. You can live with the disease and will remain suppressed, like how you treat diabetes, hypertension, and many of the lifestyle disorders, as we call it. And there are 1/3 of cancers which are probably not curable and not adequately. But in those situations, we tend to resort to making it as comfortable for the patient for the time that they have. In terms of making it, improving the quality of life of the patient for the time that they have. So, putting it in a nutshell, about 2/3 of the cancers are eminently well treated, and it's just like any other disease that needs to be dealt with.
That's very reassuring, doctor, when you put it that way, that 2/3 are controllable and that can be cured.
Yeah.
But doctor, when you are in the midst of a pandemic like we are today, does this equation go for a toss? Has it been particularly challenging?
Well, patients, if there is a suspicion of cancer, they have to come to a center to deal with it. And cancer is not a disease, depending upon the type of cancer. Some of the cancers are very slow growing. They don't have, even if you were to wait for about 6 months, nothing much is going to change as far as, but a good measure of cancers can be very aggressive, and their time frame becomes very important for us from the time of diagnosis to institution for that therapy. So we need to be aware of that, and therefore, during the pandemic, there was a reluctance for people to visit hospitals because they were considered areas of COVID prevalence, and so people didn't come. We at our center also we did see a huge drop in the number of patients coming forward for the treatment. Of course, the teleconsultations went up significantly, but there's only this much that you can do on a teleconsult in terms, unless the patient comes to you. And of course, when you want to treat a cancer patient, you need to go into depth as to what the type of cancer is, what are the characteristics of the cancer, and how you can actually deliver an appropriate treatment to optimize the outcomes in these patients. So you're right. During the COVID pandemic, at least in the first 6 months, we did encounter a decline in patients coming forward, primarily because of the fear. And there was a well-published data from the United Kingdom also, which showed that, or even projected that because of the COVID pandemic, the chances of the mortality associated with cancer is going to exponentially rise in the next 2 years, primarily because the patients did not come on time for being investigated and getting instituted with relevant therapy. So that's the problem. And when you talk about patients for other things like wanting to find out, like screening for cancer, etc., that was also a huge problem because patients never came for screening during that period at all. Yeah.
But doctor, another conversation that's been happening because of this pandemic is about vaccines. Now, suddenly everybody is also more informed, and they are the way the vaccine conversation has happened over the last year has been amazing, and it's been something that most of us haven't seen in our lifetime. So do you think that there would be expectation of maybe a vaccine coming up for cancer? Is that very far-fetched?
So the concept of vaccination for cancer has not been a new concept at all, and it's been there since the 70s. Looking at the thing, because just like the principle of vaccination is basically to generate a robust immune activity to sort of eradicate the antigen, or that is or the organism, or whatever that we are talking in terms of vaccination for organisms. We are trying to eradicate the organism because you generate antibodies against the organism. So similarly, even there are cancer-related antigens that are present on the surface of cancer cells. wherein you can exploit those or characterize those antigens and try to design a vaccine that would present these antigens to the immune competent cells, which are primarily the T lymphocytes, as we call it, so that it generates a robust response, immune-mediated response to destroy these cancer cells. So that's the basic principle of cancer vaccines therapy. And there have been attempts at doing it, especially with dendritic cell therapy, which is another unique thing, where actually you're using dendritic cells which present the antigens to the T cells to elicit a response that will actually result in robust immune-mediated destruction of the cancer cells. It is very nice theoretically to hear that, but over the past 3 decades, we have only made subtle inroads into this concept to control cancer. So while it is still being actively looked into, it is not something that has been up there for us to be able to deal with cancer in a very, very meaningful way. It can be an adjunct, but to delay probably recurrence of the cancer in those patients who have been treated primarily, that is something that we can probably hope for. But for primary treatment of a manifest cancer, that might be something very optimistic to look into. But certainly as a preventive strategy, maybe it is something. So the typical example of this is for cervical cancer, wherein women have been vaccinated against the human papilloma virus, which is supposed to be one of the causative organisms for cervical cancer in women. And basically, the vaccines against HPV 16 and 18 has been designed, and that has resulted in probably a decline in the development of cancers, cervical cancers in women. And it has now become part of a standard protocol in the Western population, though it's being implemented in India also, but there's been a lot of controversies associated with it because of certain problems that were encountered in some of the trials. But still, the principle does exist, and a bench to bedside concept has worked in this situation, and it is something that can be explored for other cancers, but you need to apply it for those relevant cancers. Actually, it may not be applicable for management of all cancers. Yeah.
Okay. So that we don't have a silver bullet for cancer.
No, we do.
Looking at a lot
if you're talking about
technology.
If you're talking about only vaccines, I wouldn't say that's a silver bullet, but there are certain silver bullets that do exist in cancer therapy. Yes. Yeah. Yeah. So especially in
therapy, yes. But I was talking more about prevention.
Yeah, in prevention. Yeah, in treatment, yes, there have been silver, but this is something that may come into vogue in the future. But there, I wouldn't say that this technology has been a smooth process. There have been a lot of stumbling blocks in terms of implementing it on a wide scale. But the success story, one of them for vaccine, is the cervical vaccine story. Yes.
Yes, true. Doctor, what do you feel about technologies, especially since a lot of startups are working in the AI space and a lot of new age technology, wherein we're talking about prevention of cancer? Is early detection the only way to prevent, or do you feel there are other pathways that we haven't thought of yet?
So one must not make a generalized statement that all cancers are amenable to screening strategies. There are a few of the cancers which have been explored in a robust fashion with several studies having shown the benefit of screening, and this is primarily with a few set of cancers, especially, and the One is, again, the cervical cancer, which I was talking to you about as when vaccine, when we're talking about the vaccines. The second is breast cancer screening, the understanding that breast cancer can have a familial predisposition, the understanding that there can be certain genetic predispositions to cancer, to breast cancer. All these have been amenable to being explored as a screening tool to identify uh, probably several decades in advance that, okay, this patient is likely to develop a cancer, and so we need to keep them on close follow-up. And that is that is probably one of the ways. And any surface cancers, for example, are amenable to screening things. For example, the breast cancer, it is something external, and I mean, from my previous from Tata Memorial, where I used to work, they brought out a very elegant study where they could decrease cervical cancer mortality by almost 35% by just simple techniques of screening patients in the general population for cervical cancer. So that is huge in oncology. To reduce mortality rates by 35% in women is huge. So there, again, screening is a very robust tool. In screening for breast cancer is a very robust tool. It decreases the chances of identifying advanced stages disease, early stage disease, and as we know, any early stage disease have better outcomes than advanced stage disease. So that is again. Similarly, when we are talking about specific population, if you're looking at lung cancer, for example, it doesn't make sense for us to screen the entire population, because when you have to do a screening strategy, you need to look at the economics of the whole thing, and how much is your screening going to decrease the mortality in these patients, or it is going to increase the chances of detection of this patient. So if you were to screen all lung cancer patients by a plain X-ray, you're likely to miss out on almost 60 to 70% of the populations that you have screened. So you need to have more techniques. And the only technique that is probably shown benefit is to do CT scans, but you can't do CT scans as a screening technique for all patients. So when you look at, when you want to enhance the possibility of identifying, so then you look at-risk population over here. You have patients who are, for example, chronic smokers, for example, who are at a higher risk for developing lung cancer. So you might just use them as a cohort and say that, hey, that you have been a smoker for a long time, so you may want to look at doing a CT scan to see whether there is anything abnormal over there. So again, these are focused kind of screenings that we see. And the other thing was, again, one of the failures of screening was, for example, for prostatic cancer, you look at PSA levels in elderly population. You look at these patients for prostate, looking at the elevation of the prostate-specific antigen. But you can have numerous reasons why you have prostate-specific antigen elevation, and just to have that as a screening tool may not be economically viable to do that, and it may not actually translate into early detection of prostate cancer also. So largely that has been given up. So it depends upon where you apply screening strategies. So in relevant areas, it is useful. Another important use for screening is for head and neck cancers, for example. We have a huge population in India who are tobacco users, and they are pan chewers, and they are all at risk. And whenever a patient such who are pan chewers, I think they go through a sequential process of developing cancer. So there are some pre-malignant conditions that you can identify in your oral cavity, and easily to visualize the oral cavity. So it might be important for us to inculcate this screening thing, not only in a cancer center, but even in the population or even at the primary health center, so that there are simple investigations to identify these. And their screening strategies will help. But I don't believe that there is something like a screening strategy to identify leukemias, for example. It just happens just like that. And there's no way to actually identify. So it is where you apply screening strategies. So there are a handful of cancers where it works, but not for all cancers.
Doctor, the kind of nuanced approach that you are recommending, which is what we need, also requires those kind of professionals and that much of a health force. And clearly, there is a gap. How do you
Yeah.
think we can address this gap, and how huge is it in oncology?
So these things, if you're going to put this screening strategies confined to cancer centers or oncology units associated with cancer, it is going to be a failure. So it has to be at the primary healthcare level, and this is something that has to be inculcated in the primary medical education, in the syllabus of cancer education, and emphasize that these things are important, and when they go into society they need to be looking at all these things, and also at the primary healthcare center. I always believe that perhaps the primary healthcare in India is probably weak. Yeah. And we do have excellent super specialty and super specialty centers, very competent doctors, but the as long as we strengthen the primary health care, we are likely to fail in really improving cancer related mortality in the country. So early detection is important. There has to be a sensitivity to understand that, okay, there could be a possibility of cancer over here, where we need to put the patients through investigations and identify early. As I said, early detection of cancer is always useful, especially for solid tumors, and the outcomes are far better than identifying an advanced stage cancer and then treating them. So what we see in our practice in specialty centers is that almost 60% of the 60 or more percent of the cancers are all advanced stage cancers that we deal with, and only around 40% are actually early stage cancer, where we can actually cure them completely. So there is a need for understanding cancer among the medical fraternity, and also there has to be some sort of what to say, understanding even in the population, and that needs to be uh, sort of inculcated through social media and so many other things that can reach out to the population. Yes.
So, Doctor, is this a very India-specific situation, or do you see it in most Asian countries, and how is it different in the Western counterparts?
So, so if you yeah, so cancers are prevalent all over the world, yeah, and it is not something that has been recently diagnosed. Even if you look at the mummies from the Egyptian pyramids, etc., they also there are being identified to have cancer. So it's not something which is, and it is there all over the world. It is only that the incidence of specific cancers may be sometimes regional. For example, yeah, for example, in India, head and neck cancers are a big problem because of the kind of because of the habit of pan chewing, tobacco use, and so many things. Uh, and and if you look at even regional incidence of cancer, if you look at the Northeast, which has got a very high incidence of lung cancer, for example, and many other cancers. And it's probably because there are more smokers over there, or probably there is something in the environment. For example, in Kerala, you have a high incidence of thyroid cancers, for example, and that they attribute to background irradiation from that is there in the beaches of Kerala. It is there. There's a high incidence of thyroid and thyroid-related problems and cancers in Kerala. In Karnataka, for example, if you look at it, you'll be surprised that there is a higher incidence of gastric cancers and in Karnataka than in any other part of India. So you have to look regionally as to what is the kind of cancers that are more prevalent to that particular area. If you look globally, some of the common cancers that one encounters commonly, whether it is in India or whether you're in the United States, it is generally in women, it is breast cancer, and in men, it is lung cancer. Uh, uh, Cervical cancer may be bigger problem in India, but it is something that has significantly declined with better screening strategies and better screening strategies and early detection of these. And also, again, the bringing in of gynecologists into the picture for them to do an adequate pap smear, and the need to do pap smears because women go to their gynecologists and do their pap smears sometimes has led to early detection of cervical cancer, and you can intervene in a better way. So I would never say that we are different in terms of, it's only that regionally there might be ups and downs in certain types of cancers which might be more prevalent, and that is true even in India. For example, other thing I would always like to say, in the north, in the Punjab belt and all those, gallbladder cancers are much commoner than in other parts of the country. So we have to address it depending upon what is prevalent in that way. And of course, some of the common cancers are the same probably globally, for example. And you have to tailor your screening strategies accordingly for those particular areas to see. And the typical example is for gastric cancer. It's very prevalent in Japan, and they have sort of designed methodologies for early detection. It's not easy to do that in the general population, but a country like Japan, which is much smaller, can afford to do that kind of a screening strategy of doing endoscopies for all patients, picking up early cancer and treating them radically and achieving cure rates. So it has to be individualized, and there is nothing like cancer burden yes, it has increased. Why is it increased? Because the ability to diagnose cancer has improved. There are more people coming forward for getting their cancer treated, and also there is better documentation of the prevalence of cancer in the various hospitals. Earlier there used to be about five or six cancer registries in India, but there's much more right now. So we are identifying more cancers, and so naturally the numbers will be much more than what was 10 years ago, for example. Yes.
Right. But just like the incidence has increased, the survival rate has also increased. There are more people who live with cancer for much longer now.
Yes, that is true, because the ways for treating cancers, the kind of treatment that can be offered has significantly improved in the last decade. And this is particularly true with targeted therapies, which has come into vogue, better surgical techniques that has been implemented, and also the better supportive care that has come into play to improve the survival of these patients. Yes. So especially in hemato-oncology, which I deal with, there has been an explosion of targeted therapies which have turned the outcomes of these diseases on their head, actually. Yeah.
So how long can you survive after a cancer diagnosis, as on today, if you get an early treatment?
So there are only two things. Either you treat and cure, or you treat and control. Yeah. So if you treat and cure, then you have the life expectancy as any other normal individual. Yeah. But if you're treating and controlling, then they need to be continuously on some sort of a treatment, like how you would treat diabetes and hypertension with medication, with the intention to keep the lid on the disease. The same thing is done in these, and it might be a lifelong treatment also, many a time. Yes.
Doctor, while most of us have access to care because we are in cities and it is easier to get in touch with doctors like you, do you feel that there is a serious shortage of oncologists for most people?
Yes, I would say that, but it has significantly improved in the last decade. Yeah, when I started off my career in oncology in 1998, 1999, there were only a handful of centers actually offering comprehensive oncology care, and Tata Memorial was one of them where I went. And there were very few centers which were training oncologists as a formal training. But now, in the last 10 years, many of the hospitals have an oncology unit, and it is important to strengthen the oncology unit of all the medical colleges, which can actually take care of almost 60-70% of the treatment. If you have a good radiation center under you, and you have a medical oncologist, and of course many of the surgeons do surgical oncology kind of a surgeries even in their routine practice. I think this thing can be largely circumvented, strengthening the medical colleges and the medical institutes where undergraduate training is being provided, and also postgraduate training would be the way to go about it. These specialized trainings, specialized units like Tata Memorial, etc., is there to train people, but it cannot actually deal with the amount of load, and you can never do justice to the volume of patients that come to such centers in a meaningful way. You need to give time to patients, and you need to give sufficient attention to the treatment, because it's never easy. But even though at the end of the day you're trying to cure the condition, treatment can never be always easy, and you need to pay attention. And it is not justified for anyone to lose a patient just because you could not give that attention to the patient because of volumes that prevail. So there is, of course, a need, and I would always say that strengthening there are so many medical colleges all over the country, and in men's services, several of them, in fact, and it's mandatory to I would say mandatory to have an oncology unit so that more people can come forward to get their treatment done. And it is not like as if you need fancy treatment always for treating. Most of the treatment in oncology is, I always tell my students that cancer treatment many a time is like mathematics. You have this kind of a presentation, this stage of the disease, this is the way that you present, you need to implement this kind of a treatment, and you will more than not find the results that you desire.
Doctor, how do you inspire young aspiring doctors to take up oncology? Because it doesn't rank among the top preferences. Correct me if I'm wrong, but
yeah, it never used to be, but now it's one of the more popular branches that people want to choose as their career. Believe me, it's one of the most sought after in the United States now. Mm-hmm. Yeah. So yes, there is a need to inspire actually youngsters to take care of oncology training. I will confess that even now, as part of the postgraduate curriculum, still oncology care is probably taking a. It's not one of those prominent things that is dealt with during the postgraduate training program, but I do make efforts to actually interact with the juniors during any of the conferences, or for that matter, any of the meetings, or during CMEs, and try to inspire them to try and join. And I have had quite a few who have come forward saying that, you were one of the reasons for us to take up oncology, which is a good feeling, I would say. But there is a long way to go as far as getting, because if you are talking about cancer being the second largest killer after cardiovascular system, you need people to be taking care of. You need more number of people to be taking care of this disease. Yeah.
If I may ask you, doctor, why did you choose to become an oncologist?
So actually, I didn't have a second choice at all. I mean, I would say that when I was, if you ask me which was the trigger point, when I joined for pathology, when I joined my third year in MBBS, I had a tremendous fondness for pathology. And cancer used to always always sort of intrigue me in several ways. And also, I would say there were two inspiring young lecturers in pathology who gave once a very beautiful talk on blood cancers. And I was pretty impressed with that lecture. And then I would also say I studied at Trivandrum Medical, and you have one of the best regional cancer centers over there in Trivandrum. And when I was doing my undergraduation at Trivandrum Medical, this regional cancer center just came up over there, and it was such an imposing structure. And it was almost probably one of the first centers which had some comprehensive cancer care. And we had an opportunity actually to, as part of our fourth year postings, to visit the regional cancer center, and it was something that sort of inspired me to continue what I had started off in my third year. So there was really no two ways, and I didn't think about anything other than oncology right from my undergraduate days. Yeah.
I hope there are many more young aspiring doctors who attend such wonderful lectures so that they decide to take up something like this.
Yeah.
Doctor, we are doing a project with Google. As part of that, there's a question hub. This is basically questions that people look up on Google and they don't find adequate or answers that they are happy with. So now that we have you with us, we thought we'll shoot the top 5 questions on cancer.
Yeah.
So one of it is on COVID-19 vaccine. Are they safe for cancer patients? And should cancer survivors get vaccinated against COVID-19?
So I'll answer the second question first. Cancer survivors are just like any other person in the community. Yeah. So they should be taking the vaccination without having any confusion about it or thinking about safety. Now, should cancer patients be vaccinated? The only thing is not because a vaccine can give a problem. It is the only question is whether the cancer patient who receives the vaccine can mount a response that will allow him to be protected against the virus. Because we know that when we give chemotherapy or any anti-cancer therapy, and even cancer itself is a sort of immunocompromised state. So when we are going to give a vaccine to such individuals, it is quite possible that they may not mount an immune response. And so technically, your vaccination is likely to fail over there. So whenever we are talking about vaccinating cancer patients, currently the general acceptance is that if about 3 to 4 months have elapsed after your completion of your therapy, it is quite okay to go ahead and take the vaccination. So because it is not the vaccine that is going to cause a problem to you, it is only whether you can mount the response at that time. And certainly cancer survivors have to take the vaccine. I'm getting about 5-6 messages from my former patients every day asking this, and I tell them that please go ahead. But if for patients who are on treatment and who have just completed their treatment, perhaps about 3 months of time before you need to take the vaccine. But do take the vaccine. I think it's just like any other vaccine that we have to take. Yes.
Okay, I think that will give some clarity to a lot of people. The other question that was popularly asked was, what are the chances of successful pregnancy or surrogacy after cancer treatment?
So again, it depends upon the type of cancer that the patient had, the type of chemotherapy that was used to treat the cancer, and also whether the patient received radiotherapy as part of the treatment. So these will determine as to whether the patient can have a a successful pregnancy or not. Yeah. So we do have a certain percentage associated with each kind of a treatment, but rarely does it go above 5% or so. Yeah. So, and currently we are quite clued in into what is the kind of chemotherapy that we have to give a patient if they are desirous of a pregnancy. Now, it is very easy in the male population, because if we feel that we always ask them for sperm preservation or sperm banking in these men. But it becomes a little bit more of a challenge in women, where egg preservation is a lot more difficult than doing a sperm preservation. So we do that. Now there are technology available to do that, and one can go ahead with it. But having said all these things, especially in hematological malignancies, we have had any number of patients who have who have fathered or become pregnant after the treatment is completed. Now, if a patient like having a gynecological malignancy, and they are treated primarily, many a time they undergo radical surgery and their uterus and ovaries are removed as part of a therapeutic. In those situations, maybe you may be able to preserve the eggs and probably look at surrogacy over there. That should be okay. But otherwise, it is something that has to be planned. It is something that we need to understand what are the type of drugs that we use which can potentially create infertility, and what is the percentage of that. There are some cancers which actually intrinsically produces a little bit of low fertility, and one of them is Hodgkin's lymphoma, for whatever reasons we do not know. So it becomes imperative for us to assess what is their sperm count, etc. Not so much for women, but in males, to see prior to starting chemotherapy in these patients. So it is highly individualized. And I would say that there is every chance that a patient, I can say so for hematological malignancies, for sure, that there's every chance that they can become pregnant after the treatment is completed. Yes.
Okay.
I've had any number of instances where they have become. In fact, for a specific malignancy, which is known as acute promyelocytic leukemia, we have even published a paper on successful parenting in patients post-treatment for acute promyelocytic leukemia.
That must be very reassuring for a lot of patients who are going in for these treatments.
Yeah.
Doctor, also, since you do a lot of research and you are in the academia, what people want to know, what is the research that proves the impact of smoking, alcohol consumption, and other kind of lifestyle factors on the cancer risk?
So, no doubt, number one is smoking. Smoking has got, I think, almost 37 or 38 different carcinogens which can actually independently cause different forms of cancers. And you name it, there is not even one system in the body or one organ that can escape the effects of which is not related to smoking related smoking as a cause for the cancer. Yeah, you say, but of course the commoner ones are those that you encounter in the oral cavity, in the lung, and also, even for that matter, gastric cancers, urinary bladder cancers, and several other cancers that we get. I mean, everything has got some causality with smoking. Yeah. So, there is no doubt about the fact that smoking causes cancer, and one of the safest ways to prevent cancer is to move away from smoking and stop smoking. Yeah, that's important. You must also understand that never smokers are better off than occasional smokers, and they are probably a little better off than people who are addicted. Who are addicted to smoking. And also, we know that every time that smoking is, whether you have smoked and you have stopped, still your risk of developing a cancer remains as compared to a non-smoker. So smoking is a strict no-no. Yeah. Now, can I say that same about alcohol related, whether alcohol can induce cancers? Well, the connect is not as robust as for cancer, but most of the time, many of the people who consume alcohol are also smokers, and that is a deadly combination. Yeah, and the chances of developing oropharyngeal cancers are, and even gastric cancers, are several fold higher in patients who are consuming alcohol and at the same time are smokers. So alcohol also is, again, as I said, chronic alcoholism is one of the primary causes for a depressed immune system. Yeah. And any depression in the immune system make you prone to develop a cancer, because as I told you in my during the beginning of this during the beginning of this thing of this talk, that you need to have an active immune surveillance to prevent cancer, and smoking definitely. Lifestyle, yes, we do have, for example, the example that we always quote is with breast cancer. There is definitely increased incidence of breast cancer with obesity. There is, and when they are coupled with other risk factors like a familial history, or for that matter, for example, breastfeeding, for example, and also the kind of nutrition, food habits that you have, everything has been uh, not like as if it is robust, but when it all adds up, and that predisposes you to cancer. And that is particularly true with breast cancer. We know also for colorectal cancer, cancers of the large intestines, etc. It was something that was rare in the Indian population in the past, but it has now almost touching the same incidence as patients in the West. That's because our diet has completely changed, and the way that what we consume has completely changed. And that has also resulted in increased incidence of colorectal cancer, which is quite high. If you look at the curves, it is significantly increased in the past 2 decades, which was not the case probably yeah, in the past, when colorectal cancer was considered one of the more rarer kind of disease, which is not the case right now. So all these, so I hope I've answered individually your question related to smoking, alcohol, and lifestyle. So with some examples, that is.
Yes,
Yeah.
yes,
It is
Doctor.
important. It is important to have a healthy lifestyle. It's important to have not a sedentary lifestyle. It's important to exercise. Yeah, because that goes a long way to add on to several strategies that will prevent cancer. Yes.
Doctor, another interesting question. This is something that I think we don't talk about enough. Is, do cancer patients and survivors need mental health care?
Yes, it is not something that it is a common problem. Yes, yeah. So we also recognize an entity in patients who have received chemotherapy known as a chemo brain. Yeah, there is something called a chemo brain. Yeah, wherein the patients experience lethargy, persistent tiredness, depression, and all these things. So it is something that has to be dealt with, and it is that is where the field of psycho-oncology also has come into picture. We at our center have an independent department looking into that, and it's all about trying to be accepting of the fact that you were a cancer patient and now you have been cured of that. And also sometimes the side effects of the chemotherapy can be chemotherapy or whatever treatment that you have given can be sometimes subtly permanent. For example, it can cause abnormal sensations because it affects the nerves, and tingling sensations, which can actually interfere with your day-to-day activities in patients. Sometimes you may have to have undergone a radical surgical procedure for this thing, which might induce or some disability. And to overcome that disability, you need a lot of mental makeup actually to overcome those difficulties and get back into mainstream. Sometimes it can be like, for example, in women having radical surgeries, mastectomy, removing of the breast, etc., can have certain something like a shaming kind of an impact on the women. But now currently there are so many techniques that are most of the time we are going for breast conservation surgeries and plastic surgeries to actually reshape the breast and bring it back to a normal look, etc. So these things and all go a long way. But certainly, your question is very apt in saying that, yes, it does affect mental health, and it is something that needs to be recognized and worked upon. Not that it can, but it can be definitely the impact of all these things can be definitely scaled down by understanding that there is something that exists, and we take help from the psycho-oncologist, or even for that matter from the psychiatry team. It's not something that one has to be ashamed of, and it helps a lot to overcome difficulties in these cases, because it doesn't pay for a patient to get treated, get cured, and remain depressed.
Yeah, true.
Yeah.
Doctor, finally, my last question for you is, what is your message for this World Cancer Day?
So I like to say that many people do ask me, how can you be treating cancer patients? I say I'm the happiest treating a cancer patients because I see them cured of the disease. Yeah. So all I have to say is that cancer is just like any other disease. It needs to be dealt with just like any other disease, and it should not be equated with death. Yeah, it should not be equated with death. You have more cancers that can be cured with effective treatment. You have to understand that cancer is there to stay. It is going to be there, and it can happen anytime during your lifetime. It can be effectively treated. Only thing, it needs to be addressed in a meaningful way and treated accordingly. So all I would say is that cancer is just like any other disease, and it needs to be dealt with just like any other disease. And that's all I have to say. And this is what I tell all my patients to when they come, because there is unfortunately a feeling that oh, I've got cancer. It's time for me to pack up and go, or I'm going to die. So just have to accept it as disease, get treated, and I'm not saying that everything can be cured, but a good measure of them can be cured.
That is a great note to end this conversation on, Doctor. Thank you so much for your time. It has been wonderful talking with you.
Thank you.